for evidence-informed policy. We are definitely so pleased to collaborate with WHO UMRO and partner with WHO UMRO and other partners. So we are co-chairing as K2P the Health Systems Global Eastern Mediterranean Regional Network, which is really sponsoring this pre-conference. My colleague Resha, unfortunately, because of urgent personal matter due to the current situation, Lebanon was not able to be with us today. I would like to thank you all for being here today, despite, again, as you many of you know, our country, Lebanon, is currently going through a very challenging time, and we have not only to fulfill our commitment, but as I mentioned before, to stand as a testament to our strengths, our resilience, and the belief that even in times of hardship, we must be, optimistic, and we must keep moving forward. I would like to really, I'm so grateful, in fact, to our partners, particularly the World Health Organization Eastern Mediterranean Regional Office, which really played a very important role in designing the series of the pre-conferences that already been going to take place in the next 2 weeks. And this is represented by Dr. Awad Mataria, as well as Dr. Arash Rashidyan. And they have provided unwavering support in this regard. And of course, we would like to thank our collaborators, Mohammed bin Rashid School of Government, represented by Emmanuel Monasser, and the University of Birmingham, Dubai, represented by Ayat Abu Akra. I would like also to extend a heartfelt thank you to all our panelists for taking part in today's sessions. I think with the spirit of I would say resilience and unity, so I'd like to go and proceed with the program. Just a little bit about the pre-conference, what you know about how, as you know, this is ahead of the 8th Global Symposium Health Systems Research which will be held in Japan, Nagasaki, in November 2024. This pre-conference, I think the first of its kind in our region. This is dedicated only for the Eastern Mediterranean region. I think this event seeks to bring certainly regional stakeholders together to explore the symposium themes from an EMR perspective, but also making sure that we are actually fostering regional collaboration, knowledge exchange. Much of the insight that will come out from this pre-conference will be actually taken forward to Nagasaki in Japan in November, but also there will be a lot of follow-up activity that certainly will take place in our region, collaboration with UMRO and other partners. This pre-conference will be delivered over 3 days, again, not consecutive one, with again, each day or each session dedicated to specific themes relevant to the region. So that's why you'll see the themes are aligned with the symposium theme, which is really building just and sustainable health system, centering people and protecting the planet. Of course, while each day was initially designed to encompass a mix of plenaries and abstract submission, I think in light of the situation, we have made decision to focus the program only on the plenary session. So today, we will have the first plenary session, which is really mostly focusing on health governance, policy for advancing equity, inclusion, and universal healthcare coverage in the EMR. In October 8, which will be the plenary 2, we'll be really talking about health system resilience in the Eastern Mediterranean region. And it will be really spot on and fantastic, I would see in sub-theme in October 8, because this is exactly what we are living now, how we navigate conflicts and many of the challenges that is taking place in the region, also including climate change. And the last plenary will be in October 15, which will be purely about research, data, and knowledge for health system, particularly when it comes to innovation, AI, knowledge translation, and impacting policy. So this is just a brief introduction about the purpose of this pre-conference, the sub-theme related to each of the plenaries, and we're so excited today. Really, thanks again for all the collaborators, the partners, for actually launching the first plenary on October 1st. Over to you, Danuka.
Thank you, Dr. El-Jardali. Hello, everyone. My name is Nanuka Jalagonia. I'm representing Health Systems Global Secretariat today. And before I begin, I just really want to acknowledge the context in which we are meeting today. And this escalating crisis is really affecting many of our colleagues, and many of them have played an important role to organize this event, but are not able to be here today. And I just want to highlight Rasha Fadlala, the lead of the regional network, and her contribution to this event. And we really want to recognize her contribution. Next slide, please, Farid. I would like to really briefly remind you about the Health Systems Global Society. This is a society with a diverse global membership that connects health systems research, policy, and practice communities, contributing to the attainment of better health equity and well-being. The Health Systems Global was founded in 2012 in response to the need of greater health policy and systems research to accelerate universal health coverage worldwide. And Health Systems Global has emerged as an international society that brings together diverse groups to take forward this agenda and promote health systems and research and its application for the health systems development. Next slide, please. Health Systems Global builds strong and inclusive communities across all 6 WHO regions, and one of which is the Eastern Mediterranean Regional Network, which has organized this pre-conference. And our membership span across 1,500 members from 110 different countries. Next slide, please. Our flagship event that Dr. El-Jordali has mentioned a minute ago is the biannual Global Symposium on Health Systems Research, and it convenes thousands of health policy and systems researchers, policymakers, advocates, funders, and practitioners from all over the globe, making it one of the largest global symposium on health systems research. Next slide, please. Dr. El-Jordali also mentioned that the upcoming, which will be the 8th Global Symposium on Health Systems Research, will be held in Nagasaki this November. And the next slide, please. The overarching theme and the sub-themes of the symposia is on the screen. Next slide, please. Health Systems Global strives to foster HPSR communities, and the examples of such HPSR communities are Health Systems Global thematic working groups and 5 regional networks. Thematic working groups are multidisciplinary groups focused on different areas of health policy and systems research, providing a platform for member interaction and knowledge exchange similar to the regional networks. And we encourage you to become part of these groups and contribute to HPSR landscapes through our initiatives. Next slide, please, Farid. Thank you. Health Systems Global Eastern Mediterranean Regional Network is strongly represented by the Knowledge to Policy Center, a WHO collaborating center at the American University of Beirut, Lebanon. The network aims to promote the importance of and build capacity in health policy and systems research in Eastern Mediterranean region. And it really tries to mobilize people in the region to engage and actively participate in HSG initiatives. Next slide. Thank you, Farid. While the much of the region's policy priorities focus on health systems, there is a limited recognition of the importance of HPSR in the EMR region. Specifically, there is a limited capacity to teach, produce, and use HPSR to inform policies, programs, and reform efforts in the region. That's why the regional network engagement plan for the region focuses on promoting the importance of conducting and translating HPSR to inform policy and action, strengthening capacity among researchers, policymakers, and other stakeholders, conducting regional meetings and webinars on health systems and health policy and systems research related themes, and increasing regional awareness and participation in Health Systems Global Symposia on health systems research. So this is very briefly about regional network and what it does, but more extensively, you can read it on the dedicated webpage of the EMR Regional Network on HSG website. Now I will pause and we can stop sharing, Farid. Thank you so much. And we can hand over to Dr. Awad Mataria, who will serve as a keynote speaker and a panel moderator. Dr. Mataria will guide us through today's discussions as we dive deep into the critical issues facing healthcare systems in the EMR region. Dr. Mataria is a director of Universal Health Coverage at the WHO Regional Office for the Eastern Mediterranean. Dr. Mataria has more than 15 years experience in health system strengthening, health economics, and health financing. For the last 10 years, he has been supporting countries of the Eastern Mediterranean region to reform their health financing systems to move towards a universal health coverage. Dr. Mataria has a PhD in health economics and master's degree in health systems analysis, following his undergraduate degree in pharmacy. His areas of expertise are universal health coverage, health systems financing and organization, social health insurance, using economics in healthcare priority settings, measuring the benefits of healthcare using stated preferences techniques, economic evaluation of healthcare interventions, and national health accounts. Dr. Mataria, I now hand over to you, and we will also grant you the sharing rights. I know that you prefer to share slides.
Well, thank you very much, Nanuka, for this great introduction, and thank you very much, Professor Jardari, for engaging us from WHO side in organizing these pre-conferences. It has been really a pleasure and delight to be organize this with you and to be working with you on this very important symposium and the pre-conferences. Again, as you had mentioned at the very beginning, we are coming at a very sensitive time with all what is happening in the region. So all my sympathies for all colleagues in Lebanon, but also in other parts of the region. I am Palestinian myself, so the situation in Palestine has not been of lesser tension in the past period. So we pray for the safety and the security and well-being of everyone everywhere. So thank you very much again for this opportunity to share with you some of the reflections on our work on the universal health coverage. So I have been asked to give you an overview of where our region stands with regard to universal health coverage, what are the challenges, and what is the way forward, the way that has been built on and endorsed by different countries. So just confirm to me that you can see my screen as I start my presentation.
Yes, now we see it, Dr. Awad.
Wonderful.
Perfect. But just if you can put the slide.
I did. It should be coming. So thank you very much again. So when we talk about universal health coverage and we talk about health system, every time I like to start by reminding ourselves what do we mean by health system, especially that nowadays we have been looking very much at how our thinking around health system has been transforming and changing. Then I will share some data about where we stand our region with regard to universal health coverage compared with the global situation. When I refer to the region, so it is the Eastern Mediterranean region, which expands from Morocco in the west to Pakistan in the east. It hosts around 670 million individuals living in the 22 or 21 countries of the region, in addition to the occupied Palestinian territory. And then I will share our regional agenda and the work that we are doing with regard to advancing health systems towards universal health coverage. So as I mentioned, when we talk about health system, so we all go back to the definition that was introduced by the World Health Report 2000 to say that a health system is about all institutions and all activities for which the primary intent or the primary purpose is either to maintain, to promote, or to restore health. I found this although it is a very short definition, it is very telling, because this means that health system goes beyond delivering services. It goes beyond the health sector. It goes beyond the Ministry of Health. So we're talking about everything that has as a primary intent to impact the health of the individuals. Now,
Dr. Awad, just I don't want to interrupt, but are you because the slides are not moving, so I'm not quite sure if you already started moving your slides.
Yes,
we
I
still
did.
see. So we're still unfortunately seeing only the first slide.
Okay,
so,
let me start sharing and share. Thank you for highlighting this.
Yeah.
It seems I should. So can you see now this one?
I think it's coming up. Not yet.
Can you see a full screen slide?
Yes. Now it's perfect. I see. Can you move it just to make sure? Oh yes, now it's working. Fantastic. Thank you.
So I had started. Thank you very much for highlighting this, Fadi. So I had started by giving the definition of what we mean by universal coverage. No need to repeat that because everyone knows it. But then to dissect and to decompose this complex construct, which we refer to as health system, in 2007, in 2007, WHO produced this report that is titled Health Systems, Everybody's Business, which looked at the construct of health system across what we refer to as the building blocks or the components of the health system. So this is when we start referring to governance, to service delivery, financing, health workforce, information, and so on and so forth. And it is a very useful framework to analyze where health system stands and what are the challenges and gaps in the performance of the health system. and also provided the definition of what are the goals of the health system, which are to improve health at the national level, but also between different population groups, but also to respond to what we call the non-medical needs, to provide services with dignity, to share information about the health of the individuals and the societies, and last but not least, to assure the goal of financial protection. Given that health, we understand that goes beyond the understanding of health system and of service delivery, and that these components might not be working in isolation, should not be looked at in isolation from one another. In 2010, we had another World Health Report that provided the description and definition and analysis of what we refer to as universal health coverage. And since then, universal health coverage became the ultimate goal of many of the health systems in the region. So many countries have been developing their national health strategies to advance the agenda of universal health coverage, being related to access to services, improving financial protection, and assuring the quality of the service that are being provided. Then in 2018, 40 years after the famous Alma Ata Declaration, there was work between WHO and UNICEF, but also other partners, to have a new look at what we refer to as primary healthcare. And again, this is coming from the fact that health goes beyond the health system, and health system is only a factor to improve the health of individuals and societies. So the new way of looking at primary healthcare, which will be discussed, I believe, at length in some of the pre-conferences, but also in Nagasaki, when we talk about primary healthcare, we prefer talking about the primary healthcare as an approach, or the primary healthcare approach, being composed of 3 components. We refer to primary care, which is the first level of care, first level of delivery, but also the essential public health functions. These are functions like surveillance, emergency preparedness and response, communication, research, and others. The second component is related to multi-sectorality, to engage other sectors into health. And the third component is related to community engagement, community empowerment. So all this happened until 2018 with the Astana Declaration 40 years after Salalah. Then COVID came. COVID hit the world, hit our region very, very hard. And it has really shaken the way that we have been thinking about health system. COVID has really shown the very importance of good governance. In our countries, in many of our countries of our region, we unfortunately have divided territories. We don't have one voice to bring in one approach for managing a national health system. It has also highlighted the importance of integration between different health programs, and as well as the emergency preparedness and response and the health system. Also, COVID has highlighted in our region, and specifically, but also in other parts of the world, the need to relook at the reorganization or organization of service delivery, to bring in the role of primary care more effectively in the delivery of services. It has also highlighted the lack of access to medicines, vaccines, and other medical products. We realize that we are the region that is producing the least in terms of our needs of vaccines. That's why we have now a huge agenda to invest in vaccine production. It has also highlighted the importance of health workers and the need to invest in health workers. And we will be talking about this during this session. It has also highlighted the need and the importance of information systems that can generate the evidence on timely manner to make the proper decisions. And last but not least, it has highlighted the importance of health financing and the need to transform our financial management systems to be able to raise the money when we need them, to use them properly, and to get the best out of these resources. And I mean, if we take all of these different observations, we have been distilling lessons on how to reshape our health systems moving forward. And one of the lessons is really related to the importance of investing in what we refer to as essential public health functions, becoming the foundation of our health system development. The second important lesson is the need to bring in equity again into health system and in everything that we are doing in health system. I refer to the importance of service organization, the multi-sectorality, health workforce, but also one of the lessons, the importance of starting thinking global health within a national health agenda, because health surpasses the geographical boundaries of any country. And I refer to the importance of emergency management as part of health system. But if we want to really summarize all these lessons in something that you would keep in mind, I think the most important thing for us now is how to bridge the gap between universal health coverage and health security. To say that these are two goals that are working together, and we need to shape our health systems to be resilient and to be equitable to advance these two goals. So if we take this universal health coverage, our focus today, and to see where we are, that universal coverage is one of the targets in the Sustainable Development Goals. It's target 3.8. It has two indicators to measure it. One is related to access to services, 3.8.1, and one is related to financial protection. We have been producing, along with our partners and colleagues from World Bank, every 2 years, a global monitoring report on where we stand with regard to universal health coverage. The last report was published in September last year at the occasion of the first high-level meeting on universal health coverage. When we look at the global situation in our region, we find that different countries are at different stages in realizing these two dimensions or two goals of universal health coverage. Every dot that you see on this scatter plot represent a country. So you can see countries that have high service coverage, but low financial protection, or low financial protection and low service coverage, and so on and so forth. But our estimate, if we look at globally and regionally, we now estimate that there are 4.5 billion people in the world, around more than 55%, around 57% of the global population that do not have access to their needed health services. And there are around 2 billion or even more that are faced with what we call financial hardship or financial catastrophe, spending too much when they go and demand their needed health services. If we want to reflect this to the region, so we looked at the service coverage in terms of what we call the service coverage index, that is a composite index of different racial indicators. Globally, the average of this service coverage index stands at 68. In our region, we stand at 57. We are 11 points less than the global average. And in our region, we estimate that 1 in every 8 individuals, 12.5%, face financial hardship when they go and demand health services. If we want to compare our region to other regions, so all regions in the world have been progressing towards their service coverage and have been progressing towards the financial protection goal. The situation in our region is really very challenging in the sense that our progress in service coverage has been slower than other regions. So now, if we, with all due respect to our regions, I mean, we are now only better than the African region with regard to our service coverage. With regard to our financial hardship or financial protection target, I mean, it is regressing faster than others. And I mentioned 1 in every 8 individuals in the region face financial hardship. And these are the numbers. I'm just leaving them for you if you want to look at the different regions and where they stand over time. My last piece of information here is with regard to the many fragile and conflict affected settings or countries in our region, where we see really that the situation of universal health coverage is really backwarded. And you see here examples from Iraq, from Syria, Somalia, Sudan, Yemen, Afghanistan, which are some of the countries. Unfortunately, now we count more than half of our countries of the region that are either directly or indirectly impacted by one form or another of conflict. But in these countries, it is where we see that challenge with access to services, where we see that challenge with financial protection. I'll conclude by sharing with you what has been our regional agenda to work with countries to advance universal health coverage, to rebuild their health systems post-COVID or living with COVID, but also taking into account all the emergencies in the region. I think what we are trying to introduce, and great that we are discussing this amongst researchers, is really a paradigm shift in our thinking around health system. What we would like to see in our health systems moving forward are health systems that would advance health rather than only treating diseases. Health system that would integrate and mainstream equity along with efficiency. We want to see a global view of our health system, not only a nationalistic view. And we want to see health systems that cater for people and societies and not only driven by providers and centered around the providers. And last but not least, we'd like to see learning health systems that keep evolving and learning from themselves. We came up with this framework to translate this new vision for our health system. So we say that we would like to see universal health coverage and health security as 2 goals. And we believe that we can achieve them by building our health systems based on the primary healthcare approach, the 3 components that I referred to, but also by integrating emergency preparedness and response, or what we call health emergency and disaster risk management, into our health system thinking. We believe if we do so, that will contribute to SDG 3 on health and well-being, but also will contribute to social and economic development in the region. For that matter, we have defined 7 priorities that we are working on with our countries in the region. Many countries, we are doing many missions in countries now to relook at their health systems, and they are very much inspired by these 7 regional priorities. The first one is to invest in where we should be starting, which is the health emergency and disaster risk management. The second one is to rebuild public health institutions. We'll be discussing this during the panel. And starting by ministers of health, reshaping ministers of health to be ministers of health of the 21st century, and ones that would cater for these dual goals, to reshape the models of care to become primary healthcare oriented, to bring in the three components of primary healthcare, to invest in our health workforce, to advance the agenda of financial protection, as well as the access to medical products. And last but not least, to do all of this in harmony and in coordination, not in a siloed and in disintegrated manner. I'll stop here. And it is really great that we are having a wonderful group of panelists, policymakers, practitioners, but also decision makers who have really occupied a very important position in their own countries to share with us some of their experiences and some of their reflections on our health systems in the region moving forward. I'll stop my screen and we can maybe move now to the panel discussion.
Yes, great. Thank you, Dr.
Okay. So again, thank you very much, our great panelists for joining us. I'll introduce our panelists first by name briefly, and then when I address them, the first question, I'll give a longer introduction for all of them. So let me first welcome His Excellency Dr. Ashraf Hatem, who is the chairman of the Health Committee of the Egyptian Parliament. Thank you very much, Professor Hatem, for joining us. We have with us also Dr. Fadi Alami, His Excellency as well, from Lebanon, a parliamentarian from Lebanon, member of the Lebanese Parliament, and chairman of Foreign Affairs and Immigrants Committee at the Parliament. And we have Dr. Khulud Muhammad Hussein Ibrahim Assaya, who is the head of Section Health Policies and Standards at the Science Department at Dubai Health Authority. And we have with us Dr. May Farid, who is the Assistant Minister of Finance for Economic Justice, at the Ministry of Finance in Egypt. And we have my dear colleague, Dr. Gulen Jelek, who is our Coordinator of Health Workforce at the WHO Regional Office for the Eastern Mediterranean. And we have Professor Shahla Zaidi, who is the Director of a Master Program in Health Policy and Management at Aga Khan University in Karachi. And last but not least, we have Dr. Emmanuel Azad, who is a professor at Mohammed bin Rashid School of Government in Dubai. So we will go into 3 rounds. I will ask first a longer question to each of our panelists, seeking their views on how things have been happening in their context and how they are looking at what are the key challenges that they have been faced with regard to advancing the agenda of universal health coverage. So, Professor Ashraf Hatem, I mentioned you are a member of the Parliament. I mean, you are a former Minister of Health and Population in Egypt, and you have been also a counselor at the American University of Cairo, and you have also played the role of Secretary General of the Supreme Council of Universities in Egypt for a period. So, from your perspective, what are the key challenges that the Egypt or the region, if you would like, has been faced with in order to advance the agenda of universal health coverage? Over to
you. Thank you very much, Dr. Awad. First of all, my heartful sympathy and for Lebanon and for Gaza. We all feel sorry for all what's happening. You know that our first attempt in Egypt to do health insurance was started in 1964, when the HIO, which is the Health Insurance Organization, started, but it was only for the governmental workers, and it was individualized, and it has both the payer and the provider in the same organization. And that was at the socialist time, at Nasser's time. In 1918, the Egyptian government started to pass a law in the parliament, and the parliament passed a law for universal health coverage in Egypt. And this universal health coverage separated the payer. We have 3 separate entities: a universal payer, I think it is represented here with Mai Farid. She is the she will represent the universal payer. We have also an organization which is a quality and accreditation body and an audit body which ensures the quality of service, and providers. And one of them is the bigger provider, which is the governmental or the Ministry of Health providers, which is the hospitals and the institutes. The law started to be implemented in 2019, but of course, unfortunately, COVID came by 2020, and there was slowing down of the law. The law has the difference between this law and the other old law, that it separated, I say, the payer from the providers, and we have different providers, governmental providers like the Ministry of Health, like the university hospitals, like the private hospitals and the NGOs, and this will be our problem afterwards, because we don't have an integration of these providers with each other to give service to the people. The law is 6 phases. It will take about from 10 to 15 years to be implemented, because we are in Egypt, we are 104 million individuals, and we have about from 6 to 9 millions also who are displaced, our guests from all over the region, from Libya, Sudan, Yemen, Palestine, Syria, and so they are living with us, and everyone who is on the land of Egypt who are officially is covered by this law. And this law covers the whole family and not the individual. So it is not individualized, it is a family. And that's why it's universal. And of course, and that's why, of course, also the tuition, the payment is higher. But we had for the first time an earmarked taxes on cigarettes, for example, and some payment from the business things. Of course, businessmen don't want to pay. This is another problem, but it is there in the law to be implemented. We started the first phase, and the first phase started by 6 governorates with small population, but the problem is the total from 2020 until now who were covered by the law is 6 million, which is a very small amount if we are compared with the 110 million individuals. But up to now, it is improving a day after day. So we are implementing a day after day, and we have problems in implementation, which is related to the integration and the work as a team, and working with other providers, not only the governmental provider, but also the non-for-profit providers, the university hospitals, which are the tertiary hospitals, and also the private hospitals. We supposedly we are starting now the second phase with another 5 governorates who are now they are bigger governorates. They have about 10 million individuals, and we hope with the experience in the last 4 or 5 years that we can be it can be accelerated more the implementation. But up to now we have some problems in the IT, in the relation between the waiting period for the people to go to from the primary care to the secondary and tertiary care. The things which faces the implementation as a whole, but we in the parliament, for example, we are going every year for follow-up. It is improving. We have now the 6 governorates. We have we are sure that we have at least 75% to 80% coverage in 3 of them, which is good. And the other 3, they are still suffering. They are about 40 to 50% coverage.
Thank you.
I'll
Thank
stop
you
here for the time.
Really appreciate it. We'll go more into the challenges and difficulties that different countries are faced with to advance the agenda of universal coverage. But thank you very much, Professor Hatem, for highlighting the success of the health system in Egypt. I think it has become a model example for many countries in our region, but also globally. It has been documented, published, and we at WHO have been really referring to it as a great example for other countries to learn from and to try to replicate to some extent based on their context. If you allow me, I would like to move to Dr. May Farid because we are on the Egypt situation, and you have described, Professor Hatem, how the 3 authorities have been established, and one of those authorities is related to what Egypt refers to as the Universal Health Insurance Authority, and we have with us my very dear colleague, Dr. May Farid, who is the Chief Executive Officer of the Universal Health Insurance Authority in Egypt, and she manages a unit that works on supporting the expansion of universal health insurance in Egypt. She has a wealth of experience in different health financing matters, but also to ensure the sustainability. She focuses on ensuring sustainability of the health financing system in Egypt. So for you, Dr. Farid, again, what is the progress, the way that you have seen it, and how Egypt, from your perspective, has succeeded in advancing the agenda of universal health coverage? Over to you.
Well, thank you very much, Dr. Awad, and thanks for everyone I'm welcoming everyone here in the panel. Regarding the progress that we have achieved, I don't want since 1964 the financial sustainability of the new one. And when we are talking about the financial sustainability, we tried to design it from the very beginning to have a financial autonomy over the funds of the system, to have some sort of forecasting that's reviewed on regular basis, so that the law itself dedicated and that we have to implement a financial and actuarial assessment every 4 years to assure the financial sustainability of the system and to introduce, if needed, any new resources to be added to the revenues of the system. So about the structure, the financial structure, and it's something important also that helped us. We had, of course, the contributions from the citizens or the beneficiaries, and we are having the subsidy from the treasury on the vulnerable groups. And we're having earmarked taxes, and this is very important. And they were not part of the tax system that already been encountered within the treasury. These are earmarked to directly to the system, from cigarettes, from toll stations, from solidarity, social solidarity. I think Dr. Ashraf Hatem has already highlighted this access, and it helped a lot in when we're having some economic shocks in the country or worldwide, even, that we are not that much affected by the treasury ability to maintain or to provide for the system. It's already something dynamic, and we can adapt the shocks accordingly. One other thing is that this system is obligatory, and there is no room for opting out, and this helped a lot in the progression of the system as well, of including everyone in introducing the universal health coverage concept within the governorates that we have already been introduced in, and it also helped in some sort of cross-subsidization between different segments of the population. Right. So I'll stop here, and maybe we can reflect later.
Thank you. Thank you very much, Dr. Farid. Thank you again for building on what Professor Hatem has shared with regard to these three authorities that Egypt has produced. And I very much appreciate, I mean, you coming from the Minister of Finance, the concern of His Excellency the Minister of Finance who has been very much into the whole process of the establishment of the Universal Health Insurance Authority in Egypt, the concern about sustainability. And you have shared something. I mean, for me as a health economist, sometimes we question it, the idea of earmarking, and the way that Egypt managed to do it is something that is commendable. I mean, this is a question to be further studied and further communicated, because oftentimes, especially with the Ministry of Finance, there's objection to earmarking towards a certain sector, being health or other. But having it been implemented in Egypt is something that one can really benefit from, and to look at the political economy behind it, how that has happened. So thank you very much. Let us move now to another country example. And again, it is really an honor to have with us a parliamentarian. So Your Excellency, Dr. Fadi Alami, thank you very much for being with us. You know, parliamentarians play a very important role in advancing the agenda of universal health coverage, being the ones who would bring in the voice of people, but also who would be entrusted to monitor the implementation of national policies, national strategies. So, Dr. Alami, from your experience, and in particular in your focused responsibility as the chairman of the Foreign Relations and Immigrant Committee at the European Union Parliament, I can see that. Can you please tell us how Lebanon has been really advancing the agenda of universal health coverage? What lessons we could distill from that for the benefit of other countries? Thank you very much. Over to you, Your Excellency.
Thank you so much, Doctor. And let me just be very blunt with the way Lebanon does things. We embarked on building a strong tertiary care network of public hospitals, because 80% of the private sector covers most of the needs of the people in Lebanon. It's not the public sector. Then we moved ahead and worked on the primary care networks that we have. And we have a good spread now, in excess of 260 of them. Fortunately and unfortunately, some of them, or most of them, they're funded by NGOs. So the issue of sustainability is at stake here. And in case an NGO stops, then this primary care network will stop. And then finally, we tried to tackle the issue of having a law in place in the parliament titled the Universal Health Coverage. We've had it for 20 years. With 20 years in the parliament, and I've been in the parliament for 7 years now, and there've been always obstacles and debates of how to proceed with this universal health coverage, because Lebanon, as so many of you know, is divided along religious lines. So if we build a universal health coverage and the authority goes to a specific religious sect, the other religious sect will go ahead and tackle it and try not to move it forward. So I guess what happened during the 2019 collapse of the economy, followed by the COVID-19, that presented an opportunity for Lebanon and its legislators to maybe start working on this UAC law that has been in place for 20 years. And this is exactly what we did. The Speaker of the Parliament referred this law to the Healthcare Committee, whom I'm a member of. And then we formed a subcommittee specifically for this program. We've been meeting for almost a year and a half now. And I think the major achievement is that we finalized the draft governance part of it. That's very serious in Lebanon and any other place. We don't have the proper governance. So we have managed to produce an entity that's going to manage the UHC. I'm very much impressed what Egypt did, and I've been in touch, and I've been visiting and attending so many activities in Egypt. I had a meeting with the Minister of Health, Dr. Abdullah Fayed, just almost 3 weeks ago. And he offered to assist us also and give us guidance and share with us the experience of Egypt. And I know with this massive population, being able to have a UHC system in place is excellent. And the way they're trying to build it gradually is also equally important. So right now in Lebanon, hopefully, if the situation permits and we're out of this mess that we have, that we can continue to meet and tackle the finance part. That's going to be the major challenge. And this is most likely where we will try to also contact our Egyptian friends and get some insight of their experience on trying to tackle this issue. We have so much taxes in Lebanon because we have a huge deficit in the budget, and we don't want to add more taxes, and people cannot afford to have more taxes, but we have to figure out a way to do it. So this is where we stand. We started, we used the COVID and the financial meltdown as an opportunity to go back and build a program, and hopefully we can get it done. Our plan was to get it done by December 2024, and I'm not sure what's going to happen now.
Inshallah, it will happen, and inshallah, all the great work Lebanon has led will continue to lead on, and the aspiration that His Excellency Dr. Firas and your Council, Your Excellency Dr. Alami, and all colleagues will be able to translate that into reality on the ground. We'll also have a chance to talk more about challenges as we move forward. But let me now move to Dr. Khulud. So Dr. Khulud, you are bringing in a different angle to the discussion and different aspect of universal health coverage with your background in setting standards and guidelines. I mean, this is something that we oftentimes miss when we talk about universal health coverage, thinking of it as only access services and undermining the importance of quality of services. So from the perspective of the Dubai Health Authority, what progress has been made in that regard? Thank you. Over to you.
Thank you very much, Dr. Awad, to be here. I just want to thank everyone here. It's been very productive just to listen to everyone's insights, and I'm very honored to be here and to speak about the DHA. In the UAE, universal coverage for insurance is mandatory. So I think one of the key successes that we have having it mandatory is to have that partnership between the public and the private sector, as well as involving the insurance companies and providers in the whole process. With regards to guidelines and standards, when it comes to developing, we are always working in alliance together with the providers. And one of the biggest achievement that we have done so far is the development of the IJADA program, which is the implementation of key performance indicators to measure quality performance in patients, increasing patients' value, in other words. Accessibility is there when it comes to healthcare to everyone in the UAE, but we want to make sure that the quality is measured and is available for everybody. And to do that, the IJADA program will measure that KPI in terms of looking into patient safety, the outcome and the quality of that outcome, health economic burden when it comes to the cost, for example, and the whole patient experience. When we develop the standards for any particular illness, we actually started with the most common ones that we have, and depending on the total claims. And based on that, we developed these guidelines and standards and align them together with IJADA programs, so ensuring that the insurance is covered at every level when it comes to that particular pathway. This way, we standardize the service for everybody so that all healthcare providers in the UAE can follow these guidelines and ensure that we're following the exact same service. In addition to that, we have the EMR system in which all health informatics system in the UAE is connected together so that we continue that value-based healthcare on the patient wherever that patient is, and we provide the exact same performance. Now, following COVID, there were other areas that came into light. For example, the technologies have arisen, and we are now moving into remote treatment and teletechnology, teleconsultations for patients, and having insurance on board on these services that we can actually access those that need services. For example, those that travel outside the country, residing in the UAE, but traveling outside all the time, or patients in the UAE that would like a second opinion from a physician abroad, how we can cross border and ensure that this is covered by insurance. Thank you.
Thank you very much, Dr. Khulud, and thank you again for emphasizing this importance of standardizing and ensuring the quality. I think there is also a lot to be learned from the Egyptian experience with the establishment of what they call the GAHAR, or General Authority for Health Accreditation and Quality, which is and established for this very specific matter to ensure that what is being provided is of good quality, starting by not harming the individuals when they receive the care. And that is central really to the agenda of universal health coverage. Again, thank you very much, and a lot to be learned from the UAE and Dubai in particular experience. Let me now move to another dimension to it, and we have with us two great university experts who are with us. I mean, we have Dr. Shahla Zaidi and Dr. Emmanuel Azad, and I would like to listen to ask you the same question. How do you see things progressing with regard to universal health coverage in our region? Maybe we can start with you, Shahla, and then we'll come to you, Emmanuel.
Thank you so much, Awad. Firstly, I'm just going to quickly update my affiliation. All of you have known me through Aga Khan University for many years, but I'm now based at the University College London, leading a similar program, which is particularly equipped to, designed to equip the private sector to contribute to SDG goals. So great to be here, and my deepest admiration for our Lebanese colleagues to host today's session in very, very challenging circumstances. I'm going to start with an example from the most eastern member state of the EMR, which is Pakistan, and later come to more regional discussions in the next round. So this is, again, building on private sector engagement, which is the area that I've been working on, looking at new models. So Pakistan, with a population of 200 million plus, one of the largest, most populous countries, has a very extensive private sector. A lot of the private providers are actually formal private providers, not informal. And the government has introduced many initiatives over the last 2 decades using private sector to manage government facilities and making them more functional. However, where the biggest gap lies is using private sector in areas where there are no government facilities, and those are the cities. Urban primary care is hugely neglected, and that's where there are very, very few government facilities. So this is about presenting a new model which builds on a different set of incentives and targets a different area. So I baked a pilot with the Pakistan government on engaging private providers, which came in with 3 new paradigms. One was to engage the small-scale private providers who are based in urban slums, where government has very few facilities, and wean away from the NGO model, because NGO model is so unsustainable and is very much dependent on donor funding. So it was really to bring in the private providers who are part of the local ecosystem, who live in those communities and whose fathers and great-grandfathers have also lived in those communities. The second thing which was different was to move away from cash-based models and cash-based contracting to non-monetary contracts. And why is that? This model was developed with formative research. Government didn't want to spend money on private providers. Any extra fiscal space that the government had was to be spent on its own facilities, to spruce up its own facilities. And private providers also didn't want any cash coming from government, because it created a lot of accountability issues. It created a lot of new set of taxation and other sets of issues for them. So this was really on a non-monetary contract, but was based on resourcing. And what people often miss is that when we talk about financing, we usually talk about cash financing. Governments have a lot of resources locked up, which are non-monetary resources, such as staff, such as supplies, such as equipments. So the government supply lines for immunization and integrated services was pulled in towards private providers. Government's MIS system was pulled in, and their community-based worker system was pulled in to provide referrals to private providers rather than far-off government hospitals. So these non-monetary resources were pulled in and formed the basis of the contract. The third part, and there are just 2 more parts to it, was defragmentizing the private sector. An intermediary contractor was built in to contract with private providers and then with the government. So you had a layer of another provider. And lastly, the most interesting part was the non-monetary incentives, the behavioral incentives of private providers. So, and these comprised of referrals from government, community workers to private facilities. So an additional footfall for private providers, branding of private providers by the government as designated sites for immunization and child integrated services, and also provision of child-friendly rooms, one window facility for registration, and family practitioner accredited trainings. So these form the set of private provider incentives which got them on board. And there's a small video regarding this initiative, which is on the Pakistan Military's website, and it's now formed the basis for the Gavi portfolio planning. Most of the planning was around civil society or government-led intervention. This is now a distinct stream on private sector provision and very much at small-scale private providers. So I'm just going to stop here with this model.
Thank you very much. Thank you very much, Professor Zaidi, for this, and thank you for updating your affiliation. You continue to be part of our region wherever you are, in UCL or in Aga Khan. You and for colleagues who are following your work, I mean, all what you have done on the health system at large, health system policy research, but also on private sector is really commendable and has been influencing and informing a lot of our work in the region, starting with the work from WHO's side. And I would like also to seize this opportunity to also adjust a previous mistake that I made with regard to Dr. May Farid, because I mentioned also maybe a former affiliation. So Dr. May, in her current position, she's the Chief Executive Officer of the Universal Health Insurance Authority in Egypt. Thank you very much, Dr. Farid, for being with us. Now let me pass to Dr. Emmanuel Azad for also your reflection on progress made bringing in a school like the School of Government from your side. Thank you.
Well, thank you all for having me to be here with you. Also, my heart goes out to our colleagues within the region. We know that it's a very trying time. We have over 13 conflicts that are taking place right now in our region, but just congratulations to the team in Beirut for still pushing forward this, working with our colleagues across the region. So based on the research and the observations from on my side and with colleagues at the Mohammed bin Rashid School of Government, we have seen several governance and policy changes. Our colleagues have mentioned a couple of them, gave some examples from Egypt, from Lebanon, as well as a UAE perspective and Pakistan. But if I can maybe just highlight, based on those conversations, there were 5 key things that came out. One, in terms of having decentralized healthcare system and policy-making processes. Also, the integration of, those primary healthcare, in addition to the importance of having those public-private partnerships, and not forgetting the insurance reforms and those digital policies. These are all great changes we've seen when it comes to advancing the universal health coverage as itself. More importantly as well, to add to the discussion is the reach of those that are falling within the low and middle income groups. We have seen that there's been quite improved access to those populations that has not been previously served. We've seen changes in terms of reducing those geographic barriers, decentralizing, and those digital transformations when it comes to health initiatives. It brought closer primary healthcare services to rural and remote areas. That's one. As another would be addressing those financial obstacles, health insurance reforms, making it much more affordable for those that falls within the low income groups. And at the same time, strengthening those primary healthcare services with the use of those public-private partnerships has really expanded the quality of these healthcare services. And we saw that targeting those specific vulnerable groups in itself, having specific policies, especially historically those marginal populations, aka the refugees, ethnic minorities, and so forth. It's to address these long-standing inequalities, and I'm not forgetting enhancing health literacy. So these, I would say, while we still have challenges, but these are really great strides from the EMR point of view in reaching these underserved populations within the region. That's it from my side. Thank you.
Thank you very much, Dr. Manuel, for this. Again, I'm always impressed by the way that the whole school of government has been established in UAE and the role that you play in bringing in policymakers, politicians to discuss these hot issues. And thank you for all of the support that you provide to the Health System Research Symposium and the organization in our region. So we have touched upon, thank you very much, colleagues. I mean, we have touched upon the question of universal coverage from policymakers' perspective, from parliamentarian perspective, from academia. And now I have with us my very dear colleague, Dr. Gunan Jedek, who's going to bring in the perspective of international organizations. So she works with WHO, and she's the coordinator of health workforce in the WHO regional office for the Eastern Mediterranean. So from your perspective, Gunan, if you could kindly shed some light on the successes and how things have been evolving. Thank you.
Thank you. Thank you very much, Alan. Thank you for the invitation for this panel. It is my great pleasure, and especially in this very, very difficult context. So I think from our perspective, overall approach and issues related to universal health coverage has already been covered by Dr. Awad in his keynote speech. So I would like to take one specific aspect from there, because we know that health workforce is a key enabler in moving towards universal health coverage. And it is key enabler in improving access to health services. And what we see is there is a direct link between and correlation between the universal health coverage index and the density availability of the health workforce. And also we have already known that there is a direct link with the health workforce availability and health outcomes. So from that perspective, it is very critical that we have the right health workforce at the right place at the right time to provide the right services with right competencies. However, in our region, we unfortunately face a long-standing health workforce challenges, and I will not go through them in detail. I think it is very well known to everybody who is on this call and in the audience. But we know that in our region, the level of health workforce shortages continues, with a projected shortage of 2 million in 2030. This 2 million figure is the estimated number for today, and it will be same in the next 10 years. What is the significance of this figure? Our share in the global shortage is increasing. While we are accounting for 10% in 2013, in 2030, we will account for the 20% of the global shortage, while we are hosting only 10% of the world's population. And in addition to these shortages, we are also facing imbalanced distribution, imbalanced skill mix, and other challenges. So in addressing that, over the years across the region and globally, we have made some commitments. I mean, if I start with the ones in the last decade, there is global strategy on human resources for health have been adopted. And then we had our regional framework for health workforce development adopted in 2017, following the global one. And then there has a number of World Health Assembly resolutions, which is committed by all our member states. Number of guidelines have already been developed and adopted. And in our regional committee, we had number of resolutions like the one on strengthening nursing and midwifery in 2019. And last year, our regional committee called for action to accelerate the progress towards the SDGs by 2030, while we're on the halfway. So I think as we are facing challenges, there are some commitments to address that. And also we have seen some progress in the field as well. We should acknowledge that. I mean, we have seen significant increase in the production capacities, number of health professional education institutions have increased rapidly, especially in the medical schools, nursing schools in many countries. But still, more than 50% of medical schools are in 4 countries in the region. So access is still imbalanced. And already this increase did not match with the increase in the employment capacities. Even though there is an increase in the production capacities, we face limitations in employing the graduates in many countries. And all these countries are the countries where the health workforce shortages are felt the most. And many countries have adopted a kind of systematic, comprehensive outlook to the health workforce. Health workforce strategic plans has been developed with a long-term approach and so on. Or some countries developed migration policies to address the increasing international mobility of health workers and making efforts to retain in their countries. And also we have seen increasing collaboration among the countries in our region on the health workforce. Some bilateral agreements related to mobility, as well as bilateral collaborations in increasing education capacities, in exchanging experience. So we have seen quite a number of progress, promising examples, good practices in our region, and some countries also invested in community outreach efforts and built primary care systems with well-defined community outreach, like in Pakistan, in Iran, and going on in Somalia. But, however, we should accept that the context in our region resulted with some pauses, halts in all these progresses. So we have some good progresses, but also some challenges continue. And I would like to stop here.
Thank you very much, Gulin, for this. Again, thank you for all the support that you are providing to the health workforce agenda in the region, which, again, it was a reminder for us. We knew it, but COVID was a reminder the importance of investing in health workforce, but also protecting our health workers who have been really taking care of us while the ones being facing the virus. This is about COVID, but if we think about the conflicts in our region, they are the ones as well who are at the front lines and are suffering the most amongst the population that they are serving. So we are a bit tight with time. So what I would propose is that we combine the last 2 sections of the roundtable discussion. Many of you colleagues have been, dear panelists have referred to some of the challenges. You have touched upon the question of financial sustainability. You have touched upon the political barriers and some governance issues. You have touched upon the shortage of health workforce, but also some issues related to health system resilience. And as the purpose from our pre-conference is to come up with concrete actions that would feed back to the conference in Nagasaki later this year, we would like to listen from you what would be the concrete action points that would come from our pre-conference session. And it's really a pleasure and honor to have policymakers with us and to have practitioners. So maybe I can start with you, Your Excellency, Dr. Ashraf Hatem, with regard to what possible actions could be undertaken to advance further the agenda of UHC in Egypt and in the region. Over to you, Professor, Your Excellency.
Thank you very much, Professor Awad. I think one of the very important things to accelerate things in the universal health coverage in Egypt is to integrate the work of the 3 entities which you have, and to work with other providers as one team, not only the public provider, which is Hayat al-Raya, which is the main governmental provider, but to have also the university hospitals, to have the non-governmental NGOs and the private providers. you know that in Egypt, in the outpatient services, we have 75% of our outpatient is given by the private and the non-governmental organizations. For the inpatients, it is different. 70% is by governmental and 30% is by the private. So, and this is a very important thing. We must change the culture of our people, because any person in Egypt, he choose his doctor. He goes to directly to a physician, to a consultant, and there is no the concept of the primary health care or the family doctor. And this is something which needs to be changed as a culture. And this is also something which we started to put in the revamping or the restructuring of all the health care, also not only in the Ministry of Health, but also in Ministry of Higher Education and in universities, because we graduate people who are working in university hospitals. We are graduating neurosurgeons and chest physicians and cardiologists. We need to graduate first primary healthcare physicians. We need to graduate family doctors, and this is the problem. We have shortage of family doctors. So we are now changing this, because university hospitals, you know that Castlania started in 1827, before the Ministry of Health by 100 years. So, and that's why we started to do this by doing a new law, which is called the Egyptian Medical Council, which is responsible for the new board, which is the continuous professional development and the professional degrees, and to start with the family medicine to be a part of, to take more than 70% of the outpatient services. And this is a very important thing. Thank you.
Wonderful, wonderful. Thank you very much, Professor Hatem, for emphasizing the importance of family medicine and family practice as the foundation of the model of care. We like to refer to this as the model of care or the model of service delivery in that context. And also your point about maybe the alignment, you refer to integration, but the alignment between the three authorities and the coordination is something to be considered. As I go to Dr. Farid for her also recommended action, I would like to mention to our audience that we will be launching a poll to ask you a question about some of the challenges that you foresee for university health coverage in our region and some of the actions. So please pay attention to that, and thank you very much for all the introductions that you are making on the chat room. Very helpful. So, Dr. Farid, over to you.
Okay, regarding I can I can't agree more on what Dr. Hatem have just mentioned about the primary healthcare doctor and the GPs, and this is something that one of the biggest challenges that we are currently facing, and we were just thinking of how we can tackle this from the very beginning with the university hospitals, from the very beginning when we are talking about the specializations of the doctors, that we need a number of doctors, that this is not a problem of the Ministry of Health and Population. This is something that needs to be from the roots to be sorted out. And also we had another thing that would accelerate the implementation of the program, that we are currently always depending on the primary health physicians only from the public sector. And this is something that needs to be expanded to the private sector as well. There's a lot of GPs in the market that need to be contracted by the Universal Health Insurance Authority, and this is a plan that we are targeting to achieve within the next 3 months, as we are going to have a big campaign of positive incentives for the GPs from the private sector to be part of the system. Also, the public-private partnership, when we are talking here not only on the provision of service, but if you're talking about a national program like the Universal Health Insurance Program in Egypt, we need to see all that access that can help us to, or enable us to accelerate the process with the private sector in terms of technology, in terms of the TPAs and the claims processing, in terms of even the institutional capacity and enhancing the capacity of the people. So there's a lot of axes that we can actually target in when we are talking about the private sector, not only on the provision of service itself. Still, the provision of service is one of the very much important axis. And again, I want to acknowledge that the university hospitals and their credibility and their ability to provide service for the citizens in many governorates. That's very important, and we are trying to have some protocol with them currently in order to enhance their capacity to be important player in the system. So these elements we are having them like a priority. The technology and the digitalization of the system is also playing a very important role in the acceleration of the implementation. Currently, over the last couple of years, we were having some struggles with having the system in place, having the integration of all the databases in order to have proper forecasting for the number of people, for their status, for their contributions, for everything. And this was one of the biggest challenges that also is now about to be finalized by the end of the year, and will hopefully help in the better acceleration in the process at large. Thank you.
Inshallah. Thank you very much, Dr. Mai, for this. And I like very much your reference to the private sector. I think Egypt has been also leading the work that you are doing in the region on how to engage the private sector for universal health coverage. And I've been honored to be part of 2 consultations on the matter. So that's something, there's a lot of learning there. And as we speak, we are organizing here in WHO a workshop on costing benefit packages. And this morning I was listening to colleagues of yours who were talking about the benefit package design and its costing. And again, commendable work. Congratulations for all these achievements. May I come now again to you, Your Excellency, Dr. Fadi Alami. Again, if you would like to highlight a couple of actions that would benefit Lebanon and the region to advance UHC. Over to you.
Thank you, Doctor. I think I'm a proponent of the private sector, and I'm a firm believer that maybe the private sector, provided you have the PPP law in place, should be so much involved in managing the public hospitals. We have a structure of governance in Lebanon that's not working. We have not achieved high utilization in our public sector, and I think it would be equally beneficial as far as implementing UHC to have the public hospitals that we have under the PPP law, which is a very good law that we have, and we don't use that much. Another thing that I think is required for a successful UHC is to have, again, a strong gatekeeper, which is the primary healthcare. So we need to structure a policy where they will play the gatekeeper at those centers, and for them to do so, you need to be equipped with sufficient number of GPs and family medicine doctors. And I think His Excellency Professor Ashraf mentioned that too, that there is a shortage across the board when it comes to family medicine. In the minute we have a policy in place and a law in place where they will play the gatekeepers and their presence is mandatory before patients can go to hospitals strictly, then I think that we're going to provide them with a good opportunity of work and lots of work once we have this policy in place. And that's going to be a good incentive for them to specialize under family medicine and you name it. Another actionable plan would be to have a good integrated information technology, because the essence of having UHC is really to curb the inflation. Healthcare inflation has been on and on and on. It's going to continue to do that due to innovations, to advanced discoveries in medicine, technology, you name it. So the average age is going to go up, and meaning that will be a more demand for consumers and healthcare consumers and services. So we have to have a strong, good, unified, up to a point information system that can really take the information, analyze it, and support the Ministry of Health and the authorities in order to manage and provide the sustainable finances for those programs. Last a point that I'd like to stress is gradual implementation of UHC. Whether you want to do it by region like Egypt did, or you want to do it by gender or by age, but it has to be gradual in order to ensure its sustainability. And this is where we need to focus on. Thank you.
Thank you very much, Your Excellency, for these. I mean, your reference to the private sector, I have to say a word here because, I mean, we see the private sector is a very important partner of the whole process and a stakeholder, obviously, of the health system. The way that we have been pitching it is to say that, first of all, we want to know what happens in the private sector. So to assess the private sector, but then to govern the private sector through proper regulation, through proper regulatory framework, and then to partner with the private sector, the examples that you had given, and to learn from the private sector. So both public and private have virtues and have challenges, and it is working together through a mixed system, the way it has been evolving in the region. That might be the solution moving forward. But again, a lot to be learned from the experience of Lebanon, in particular for this. And what you mentioned about information technology, I'm sure it's a delight for my dear colleague, Dr. Rashidian, who is joining us. And he will be in a few next pre-conference, we will be tackling issues related to information systems and information technology. But now let me move to Dr. Khulud. Again, what would be your recommended actions to advance the agenda to accelerate the progress towards UHC in our region? Thank you very much.
Okay. I totally agree with my colleagues from Egypt and Lebanon about empowering the healthcare providers. But I feel as well, it's very important to empower the patients, because at the end of the day, this is a patient-central approach where we want to attract them to use the technology or to understand what's happening in the system. So one way of doing that is having transparency when it comes to doing the policies and standards. Patients should be aware, the end user should be aware of what's happening with the governance, especially that now technologies are rising and we are not able to keep track with it from a governance perspective. But if we have that transparency ongoing, we explain to the patient what needs to be done and how we can reach to them. One example we had in the UAE was actually prior to the pandemic, was opening a telehealth service at the government sector, in which we were able to access care for everybody in the UAE. Patients were not interested in using the system because they weren't aware of what's happening and what's being there. We had to train our healthcare providers, family physicians in particular, put them on the system, and then they were able to see patients. This exact system during the pandemic was open for everybody from all around, from every background, from all around the world to be used. And this opened doors to actually enhance that further and going across borders to access. I think my colleagues have highlighted that there is shortage in healthcare providers, and this is a global problem, not just in the UAE, but everywhere. And I think it's about time on how we can use these technologies to access and give that universal coverage to everybody. Because at the end, we just don't want just to reach and access healthcare, but to provide that quality of healthcare. So the enhanced comes with training those providers, which will be using this healthcare system. The other area that I want to focus on is leadership. And it's very important not just to have a systemic leadership in which we have a systemic framework on how we're going to tackle this universal health coverage, but as well to have a transformational leadership and a systemic leadership. Transformational leadership is actually going down to the level where we talk to people and see how we can transform the system and improve care. And a systemic leadership is pretty much what we're doing right now in this panel discussion. We're actually listening to each other, hearing from each other, learning lessons from each other so that we can improve this and make it a global success.
Wonderful.
Thank
wonderful.
you.
I mean, these are jewels, what you are mentioning, Dr. Khulud. If I want to push it a bit further, your first point about empowering patients, I might even say empowering people and individuals, because we would like the health system to cater for people rather than only for this, before they become sick and before they come there. And this is one of the components of the new primary healthcare approach. I'm sure that you will agree.
Absolutely. I agree with you. It's an individual-based system. So we're moving down the line from sick system into preventive medicine and down the line to self-care as well. Thank you for highlighting that, Dr. Awad.
Thank you. Thank you, Dr. Khulud. So may I now move to you, Professor Zaidi, again, what actions you would recommend for us to take forward to advance UHC in the region?
Thank you, Awad. I've had the pleasure of working with you and your team for several years on looking at regional data. And I think where I would come in from is to invest more in stewardship. We have a lot of very promising examples, very large-scale arrangements in the EMR, and I think these can be further, the promise can be built on further through stewardship. I would probably recommend 3 actions, and all of these apply to the stewardship ecosystem. One is attention to a particular type of provider. There's been a lot of attention to hospitals because of the insurance schemes that are prevalent in many EMR countries. But more attention is needed to the primary care providers, how these can be built in further within existing systems, and each country will have its own starting point. And particularly within providers, perhaps just press more on for-profit providers. Not all countries have a large NGO ecosystem, and NGO ecosystems are also not very sustainable. So to look further at how private providers can be built in. The second recommendation would be that a lot of the initiatives are rather disparate. Some are insurance models within the same country, some are infrastructure PPPs, some are management contracts, some are service delivery contracts. So the arrangements to bring in private providers are promising, but they've come in from very different angles and very different ideological perspectives. So under the UHC, we need a common single plan through which disparate arrangements can be glued up together to a common unified goal of UHC. So we need that PSE, private sector engagement plan, under the UHC. And probably the third is about approaches. So we often look towards OECD countries for PPP arrangements and approaches, but in these sort of settings, in the EMR settings, those approaches cannot be applied in their totality. So the approaches towards private sector can't be terribly transactional. They can't be terribly legal. They can't be very admin heavy because those systems are not in place in EMR countries. So the sort of arrangements would be simpler. There is, of course, more work needed on quality regulations, more on cost control, more on formalization and accountability. But at the same time, there needs to be simplicity within these arrangements so that both the private sector and the public sector, it can tie in with capacities of both the public and private sector. And very finally, just connected to that, we've looked at everything usually from the lens of public sector in all countries, not just the EMR, but in most countries. It's so important to look at arrangements from the lens of the private sector as to what will work for them. You may have a good arrangement, but private sector may not buy into it, may not be tempted to apply, or may not work well. So it's so important to have dialogue platforms, communications to co-design models. So I would stress convergence of interests between public and private sectors while avoiding conflicts of interest.
Excellent. Very nice statement. Thank you very much, Shahla, for highlighting this. Manuel, may I come to you now?
Sure. Thank you. So 2 key, I would say, our colleagues have elaborated on a couple of really great recommendations. One of it, I just want to go back to your keynote, during your keynote, Dr. Awad, in terms of the 7 regional priorities for rebuilding the health systems in order to advance these dual goals of universal health coverage as well as the health security. And one of them that stands out really much for me is the health emergency and disaster risk management. Why I'm saying this is a region we currently have 13 conflicts that are ongoing at the moment, right? Now with Lebanon might be 14, it might, I can't remember if it would be included now. But my point is that we just launched 3 weeks ago at the School of Government an executive diploma in emergency and disaster preparedness for healthcare professionals, first responders, your private sectors, everyone across, anyone who are in the field of emergency response within this region, well, particularly in Dubai, we're piloting it at the moment. So just to stress continuous development in terms of capacity building, this is really, really critical, especially for our region at this point in time. And then at the same time, as as a consequence of what's currently happening, we have vulnerable populations, and I've mentioned this earlier. So making sure, going back to that slogan, health for all. This is not a new slogan. We know this originated in the 70s and 80s from the Director General of the WHO. And during the Alma Ata Declaration for Primary Healthcare and so forth. But ensuring that these vulnerable populations are not left behind, right? Making sure we have those targeted programs in place, mobile units to reach them, having inclusive policies. And our colleague talked about NGOs as well, making sure our community leaders engage with our NGOs, and also not forgetting those creation of those culturally health services and educational materials across the board. And at the same time, having systems in place so we could try to understand the lessons learned, monitor and try to track those health outcomes for these vulnerable groups at large. So these would be my two additions.
Wonderful. Thank you very much. Thank you very much, Emmanuel, for these very key points. And as I pass the floor to my colleague Gulen, there is a request for all the panelists to kindly put your cameras on. If it is okay with you, we would like to have a photo, a screenshot for all the panelists together. And at the end, we would like also our participants to put their videos on to have a full family picture, if that is okay with everyone. So Gulen, what actions would you recommend?
Thank you very much. I think this is great time, and we are at a very opportune time. At the same time, we are at a very challenging time. As you know, we have our new regional director started this year, and she introduced three flagship initiatives, and these flagship initiatives are very critical in advancing universal health coverage, especially two of them. If we really would like to emphasize access by all to quality health services, it is very important they have access to health workers. Health workers are there, and also they have access to medicines, technologies, and supplies. So one of these flagships is about health workforce, and it builds on the call for action from last year's regional committee and emphasize investment. One of the key challenges in our region and globally in not progressing as desired in health workforce area, even though there are a lot of efforts, in chronic underinvestment. So it emphasizes investment. We need to increase investment, but more investment is not enough. I think we need to invest better. We need to invest smarter. Where are the priorities? Where we can get the high impact? And as an immediate action, this initiative emphasizes the investment in primary care workforce, because they are at the forefront, first contact access to the health system. So, and in our region, we feel the weaknesses. We feel the weakness access to primary care workforce and community outreach. So it is very important that we optimize the use of existing workforce in the case of shortages. We introduce measures to recruit people to the primary care and retain them there, with a special emphasis to their safety, security, and well-being, empowering them, and also producing more people oriented towards serving at the primary care level.
Wonderful.
And then I would like to investing more, but
Yes.
we also take into account we have to invest
Better.
in future, because investments will yield the results for the future, and we are in a very, very rapidly changing context. So we really have to look at it, and we have to how we can improve the quality of health workforce together across the region, which emphasizes that we really have to work together. I think solidarity, partnership, and collaboration across the region will be critical if we really would like to move health and health purpose are transboundaries. Thank you.
Thank you very much, Gulend, for these, again, for highlighting the flagship initiative of our regional director that you are leading on the agenda of investing more and investing better and investing for the future of our health workforce. Dear colleagues, every nice thing comes to an end. We are 2 minutes behind the schedule. Thank you very much for keeping us almost on time. So I really, really appreciate that. And I very much enjoyed it. And I hope that everyone listening to us has also enjoyed it. I would hand it now to my colleague, Dr. Ayat Abu Agla. I think you will be taking the floor from the participants for their discussion. Thank you. Thank you, Mai, for putting the camera on. Wonderful.
Thank you, Awad, and thank you, colleagues, for joining us for a really, indeed, very informative and interesting session. My name is Ayat Abu Agla, and I'm one of the collaborators for this event as part of the University of Birmingham, Dubai, but also in my capacity as chair of the thematic working group on teaching and learning at HSG, and also climate change and health systems resilience. So we have a number of questions on the Q&A, and I'd like to start with a question from Dr. Ahmed Mendil to Professor Hatem. So how is Egypt delineating the roles of the Ministry of Health and Population, UHIA, EHA, and GAHAR in the implementation of new system of health insurance? Professor Hatem?
Yes.
Over to you.
The Minister of Health, the role of Minister of Health will be mainly in the putting the strategies, the goals, and also in the preventive side, in disasters, in emergencies, and also the Minister of Health himself is the head of a committee which integrate and manage the three, oversees the three entities. But GAHAR, for example, which is the quality and the accreditation body, starts by putting for the standards for each provider. Either it is a healthcare provider, it is a clinic, or a secondary care, or a tertiary care, and then after that, when a provider, which is either governmental or a public provider, or a private provider, or a non-for-profit provider, or a university one, which is also, it is a public, but it is university, want to enter the system, it goes to GAHAR first to be enlisted in the system through the checklist. And if it is okay, it is enlisted, and they pass this to the universal health payer, which is the universal payer, and the payer put the contract, and they are monitored by GAHAR. The third one is the backbone of the system, which is the public entities, which were first in the past were managed by the Ministry of Health. They will be managed by this entity, which we call it Hayat al-Rai. So this is the role of each of one with each other, and above them will be the Ministry of Health to put the goals and the strategies. Thank you.
Thank you. Thank you, Professor Hatem. Thank you for that. Ahmed, if you're still with us, I hope that indeed answers your questions and gives us an overview of these different bodies that interchangeably regulate health and health services within Egypt. Another question from Dr. Sheikh Badr. Public health services are not adequately seen as part of the traditional health service bundle. What could be the strategies to address this and to bring in visibility and focus to the broader public health interventions as part of UHC? So this is a question to the panelist. Can I pick on Gulen to answer that in addition to any other colleague?
Thank you. Thank you very much. I think, thank you, Sheikh, for just raising that, because that was another issue which we have raised. It is one of the 7 priorities, as Dr. Awad mentioned in his keynote in the region, and especially after COVID, we have once more emphasized and highlighted the importance of essential public health functions. And in our region, there's a special attention paid to that. And we have, after COVID, we have relooked at our essential public health functions for EMR, and we have revised them. And also we are working on, we have worked on a workforce competency framework to deliver essential public health functions. And we are working with institutions to improve and increase the capacities on the education and training of public health professionals, because we really need to increase the number of public health professionals in this region with the relevant competencies. So I think a lot of emphasis is ongoing in that area. But still there is a lot to be done. We have to, and I didn't have time, but also under the flagship initiative on health workforce, together with the primary care workforce to deliver essential public health functions is also part of the priorities. Thank you.
Thank you. Thank you, Gulen. Professor Ashraf and Emmanuel, you both have your hands up.
Yes, I was just want to say that when we started the law, which in 2018, the public health as a whole was outside this, because it was the role of the Ministry of Health and the role of the government. But after COVID, as Dr. Gulen was saying, we are now changing the law. We are amending the law, because it will be paid by the government, but it will be implemented by the providers of the universal health coverage. So vaccination, for example, any public health prevention and anything which needs preventive therapy will be given by the providers, but will be paid by the state, by the government, and not by the insurers. Thank you.
Thank you. Thank you for that addition, Professor Hatem. Emmanuel?
Thank you. I think it is a brilliant question, because from day one, I even me as a young couple, maybe about a decade back, doing some research in universal health coverage, the question came to mind, So I think, firstly, we really need to go back to basics. We need to redefine the whole UHC package, and it's great to see that this is one of the policy agenda, well, one of the main priorities at the WHO Emerald Office. So ensuring that we have clear-cut guidelines with respect to what constitutes those public health services, and then also the policy alignment with the national strategies, with the local strategies and so forth, making sure it's, you have that intersectorial linkages, and recognizing that health is not a silo ministry or a silo sector. It's very much integrated with education, with housing, with environment, and so forth. So that's my 2 cents to this. Thank you.
Thank you, Emmanuel. Well said indeed. Health workforce is the backbone of our health system. Dr. Sheila, please, over to you.
Thank you. So what I've seen is that even with very well-defined health service packages, which have both the curative elements and public health services, private providers may not give that much attention to public health services. They often gravitate towards their comfort areas. So they need to be drawn in again and again to public health services. You can have different strategies. One is recognition, build them up, recognize them, celebrate the public health services that they deliver. So focus on one or two low-hanging indicators and, build up the recognition activities on that. The other is take a couple of, public health services, key core indicators, whether it's immunization, nutrition, whatever else, and include some kind of performance-based payment reward on that, which involves more measurements, which is a bit more administratively complex. But these are two ends of the strategies. Private providers won't gravitate unless they are pushed.
Absolutely, absolutely. Thank you, Dr. Sheila. Another question, moving on to Dr. Ross Miller. To the panelists, the role of primary healthcare is a key recommendation by the panel. So do colleagues have any example of best practice that can be adapted by others? Dr. Awad, should we start with you? You're on mute.
Yeah, thank you very much, Dr. Ayat. I was reading that question again. So the role of primary care is a key recommendation by the panel. Yeah, I mean, this is the question of the primary care, right? I mean, this is at the central piece of our work on universal health coverage. I mean, first of all, we try to distinguish between what we want to achieve, which is universal health coverage. I may add also health security, and then the approach for this is the primary healthcare approach. And I would like to remind everyone the three components that I have shared in the presentation. Now, when it comes to the way that we want to organize service delivery, so it was mentioned by our panelists repeatedly, the importance of gatekeeping, the importance of having people-centered services around a primary care physician or primary practitioner to bring in a team around that service delivery, not only the medical doctor, but also the nurse, the other technicians around that. So the way that we are now working on and shaping the service delivery is through developing what we like to refer to as primary healthcare oriented models of care. And in primary healthcare oriented models of care, without going into too much details, we have identified 6 elements. So we start by saying, what is the population that we want to cover, then the services that we want to cover for them, then the service organization, service design, how many levels, platforms, relation between them, and then the community engagement, the role of the community, and the 6th element is the financing arrangement for that. So we are working with countries and shaping those models of care. We are doing it at subnational level, at district level in some countries, and that would provide lessons for expanding the delivery. So in a nutshell, primary care is the foundation, and primary care is the approach for health system strengthening. And that is, we believe, to be the most efficient, equitable, and resilient way of advancing the agenda. Thank you very much.
Thank you for that, Awad. Dr. Alama, will you like to add to that?
Yeah. Like I said, I think you have to make it mandatory. So it has to be integrated within the system. If you're going to have a good geographical spread of the network that you have, so you'll have a good coverage for easy access and equity of care, that's one issue. But if you don't have a integrated policy component, making primary care for non-trauma cases is a first entry level, then it's not gonna work well. Even in Lebanon now, where we have insurance companies, I'm so surprised that even when they sell health insurance, they do not make it part of their policy wording that you have to at least once a year go through a primary care or a family medicine doctor or a primary care center for yearly physical. So at one point, you have to have it integrated with a strong policy term in order to make the system effective.
Thank you, Dr. Fadi. Dr. Khulud. You're on mute.
Thank you, Ayat. Thank you for your question, Ross. I think it's very important to have that foundation of trust when it comes to any health system, because you want to empower those healthcare professionals in order to provide the care that is needed for the patients. I think I gave an example earlier about the telemedicine center that we created in the government sector in the UAE. This exact same center that we also had challenges with the healthcare providers because they wanted to make sure that their liabilities are protected. So by empowering them, we had to ensure that we give them the proper training that is needed. And we also provided them with guidelines. And I'm glad to say these guidelines are now international guidelines to help them, to support them, to empower them, to assess them in order for them to actually be able to provide the care and feeling that they are supported by the governance and by the country. Another thing that I would like to touch on is actually the UAE healthcare vision strategy in 2030 has made significant movements and strides when it comes to primary healthcare in general. So, for example, defining the role of a physician as a family physician, what are the requirements for that, what sort of integration that's needed to manage non-communicable diseases, the preventive measures, and then allocating this comprehensive healthcare systems all around the UAE to provide the care in different communities and have that continuity of care with the patient.
Thank you, Khulud. Thank you for that. Before I hand over to Fadi to end the session, I'd just like to emphasize on the era that we're in, indeed an era of public crisis. You mentioned the pandemic, which drawn our attention to how chronic underinvestments in our health systems indeed compromised human health and leads to serious economic and social setbacks. We've witnessed the most vulnerable countries fall further behind. Today, a lot of countries within our region are in conflict. Lebanon, Gaza, including my country, Sudan, to count a few in the region, and indeed have challenged our investments in human resources for health to build more resilient health systems. We're deeply influenced by the geographies of power, recognizing the disparities in decision-making within our 21 countries within the region, being tasked to restructure, to transform, and to upgrade our health systems, our health workforce to meet universal health coverage and development goal. So the challenge is grand, but indeed, hopefully, we will be up to it. Over to you, Fadi.
Thank you so much. Thanks, everyone. Thanks you, Dr. Ayat, for the facilitation Q&A. Thanks, Dr. Awad, for the great presentation, the keynote presentation as well, for the excellent moderation. But really, thanks from the heart for all the panelists for this really quite insightful reflection on the experiences. I like how this session went because it really clearly covered, the what has been done so far in our region when it comes to universal coverage. It also covered how each country have moved forward with the legislation and the implementation and the scaling up, but also it mentioned also this so what part, what else need to be done, what is the unfinished business, what is the next step, and also how we would like to look at improving population health outcome as a result of the universal coverage is a means to an end. It's not an end in itself. And I think this is very important to keep this in mind. The role of private sector has clearly been mentioned, the different modality, the different intervention, the role of public health. So all this is a great insight. Before I wrap it up, I wanted to also mention that at the end, all this reflection and insight that's coming from those pre-conference sessions will be taken with us as AMRO to Japan. And I think it's, and I know that many also health system researchers are also listening to us, either in this webinar today, or they will be listening to the recording later on. And I think we need also to send the message also to those health system policy researchers from our region, what that means for health system research priorities. What are some of the insight that we need? Clearly, all countries are going into development and implementation. We need more research on the evaluation part. We need more research on the monitoring and evaluation. We need researchers to provide real-time data and evidence to policymakers in order to scale up the implementation of the universal healthcare coverage. So a lot of other priorities that should come on the agenda for health system and policy research, for academic institutions, others, to join efforts with policymaking institutions and policymakers, and actually make sure that we have really an effective and impacted model. I'm sure this discussion will come into plenary 2, and plenary 3 will be mostly in October 15, will be mostly focused on the use of data, use of technology, but also on knowledge translation. So again, before I give also the closing to my colleague, Dr. Arash Rashidian, I really want as K2P, at EUB, we would like really to thank our partners, specifically the World Health Organization, WHO, EMRO, Dr. Awad, Dr. Arash, really for great support. We would like to also thank Mohammed bin Rashid School of Government with Dr. Emmanuel Monasser, and also the University of Birmingham in Dubai, Dr. Ayat Abogla, for also the great efforts. I want also to thank the SSG Secretariat, Nanuka, and all the team of SSG for the support. This is a great successful launch of the pre-conference session, but certainly more to come. And again, we're so happy that we have done that, again, at a time where Lebanon is being really under attack, under severe aggression. But I think all of us here, it shows really and sent a clear message of resilience and unity. So thank you so much for being with us. Dr. Arash Rashidian, the last words are from you as the bishop. Over to you.
Many thanks, Fadi, and many thanks, colleagues. So first of all, I mean, I'm really grateful to everyone here and the panelists. I really enjoyed listening to all of you, and also my colleagues, Awad as the chair, and also Fadi and your team, and everybody in the HSC. I mean, that's absolutely, and it's a pleasure to see, I mean, old friends and good colleagues all here. What I want to say, first of all, I mean, I'm following what you said, Fadi, at last, and also some colleagues when they opened. I mean, our region is under unprecedented emergency situation. I mean, something that probably even worse than what we had seen before. And our region has seen a lot. So I mean, that's really, and within that, my kudos to you and colleagues in Lebanon working like this in this situation, and also having my colleague from, I would say, talking about Awad as a Palestinian who was also serving the region, and then all the suffering that the people of Palestine are having these days. And then obviously it's affecting several other countries. So it's not just limited to these two countries. But anyhow, so within that, I just want to say maybe a couple of sentences. The focus today and from the panelists and from the discussion was on health system aspects. And this discussion will continue in the second panel and the third panel. When we are talking about the health system research symposium, the issue becomes also about the evidence of effect of whether those things that we are talking, how they are working, how they can be improved, whether we are sure of what they are promising, etc. So the data and evidence part are actually having two games that they play. One game was referred to also earlier by a couple of panelists, is that they are part of actually day-to-day decision-making in the process. So they are part of the health system, and within that, they cannot be seen as a separate issue. These are part of the system. You cannot have a functioning primary care system in the private sector if you do not know what's happening. So the data should be part of that. But then the same data also helps you to assess whether it works or not. And then sometimes in the health system research community, which I am proud that my professional life has been within that camp, is that sometimes we ignore this element of it. As long as we can do research, then we ignore the data part. It's not just about being able to do the research on it. It's actually to enable the person who is doing the service delivery at the start to the end, being able to do that. And we see many problems, and then those become forward. The same goes for evidence from research, whether we use it in one way or the other. So with that, I refer to two things, two initiatives that we worked in the region. One was that an assessment that we did actually with colleagues in Awad's department a couple, I would say maybe 3 years ago. We assessed the status of guidelines being used in the primary care sector in countries of the region, especially in the private sector. And it was, as we all probably know, was not good at all. So I mean, so many of the private sectors are not using it. There is no system in many countries. The system, if they are there, they are not being very well followed. So those elements are there. But then on a good news, what I want to share is that what the achievement that Egypt had in the last year, and then so establishing the national guideline program, announcing it, colleagues Professor Hatem referred to the issue of the Health Council in establishment of that in Egypt. And then that became part of the national program, bringing the academic part into the system part, as well as a national guideline program, not only for clinical care, but also for public health. And that's something WHO has been proud to work with Egypt closely. And then these are the things we hope that we do more together and expand further. So with that, I stop my so thanks for giving me the last word. The last word is thank you. We really enjoyed it. And thank you, Aya. It was excellent management of the question part as well. So that was excellent.
Thank you, everyone. I think Nanuka is asking us to stay for a group picture. Is that correct, Nanuka? Is this what you're asking?
Yes, Dr. El-Jardali, that's what we are asking for.
Okay.
We want to have attendees on the screen.
Sure.
So we have that.
Okay. And are you going to tell us when we need to log off?
Or when we need to smile?
Just that we are promoting our attendees to panelists. Farid, if you could kindly help me with that.
Yeah, because I know some entities has also logged off before 3:30 just for other engagement, but at least we have I think 15-16 people still on session.
Not everyone accepting the invitation, but
I think we should go ahead with what we have, Nanuka. Just I think it's fine if some people might not be comfortable, it's okay.
The screen. We will just make sure we invite everyone and then we can take a picture. Thanks, colleagues, for joining. I know we're past 4 minutes now. Thanks for your patience. I think we have now invited all who are in the technical. Apologies. It's taking a bit of time. I really don't want to miss anyone, but I think that's all for now. Thanks. Okay, now I will take a screenshot, and if you do not mind, we will post it on our Twitter and social media accounts.
Sure.
And yeah, we can smile, and thanks everyone for being on the screen and accepting the screenshot. Thank you so much.
Thank you. Thanks, everyone. Bye-bye.
Bye, everyone. Take care. Be safe.